Explanations for phobias and their treatments. Phobias are part of a group of mental disorders called anxiety disorders. Most people who suffer from phobias know that their reaction is irrational and this is a cognitive symptom, but this does not stop them from experiencing it. There are 4 subtypes of phobias: animal type, natural environmental type, for example, fear of the dark, heights, water, and storms, blood injection injury type, and situational type, for example, enclosed spaces and flying. Behavioral symptoms of a phobia include an avoidant anxiety response and disruption of functioning. Emotional symptoms include persistent excessive fear and an immediate fear response, such as panic attacks when in the presence of a stimuli. Behaviorists believe that all behavior is learnt and therefore can be unlearnt. Phobias have been learnt due to associating a previously neutral stimulus with the fear response. This is a conditioned response. The theorist Pavlov studied how dogs could be conditioned to salivate by learning that the sound of a bell would mean food. By slowly conditioning them to believe this was classical conditioning. If a fear is formed through classical conditioning, it is then maintained by operant conditioning. This is the 2-process model. The case study of Little Albert in 1920 by John B. Watson and Rosalie Rayner was developed on Pavlov's studies. He initially showed no fear of a stimulus. However, Watson conditioned this fear by producing a very loud noise every time Albert was shown a white rat. After repeating this, Albert began to associate the white rat with the loud noise and began to cry only after seeing the white rat. The behaviorist explanation is scientific and can be measured. The experiment with Little Albert shows clearly how a phobia is created and maintained, and shows how classical conditioning works scientifically. This has allowed for a lot of support for the behaviorist explanation. However, 50% of people with a specific phobia can't recall what triggered it in the first place, showing how conditioning may not be the cause of people's phobias. The behaviorist approach could also be considered overly deterministic in terms of the 2-step model. It suggests that people are programmed by environmental experiences to develop a fear and ignores people's own free will over the situation. As well as this, the behaviorist approach is reductionist in terms of simplifying complex mental disorders as being caused by experiences of association and conditioning. It disregards other factors such as experiences in childhood and biological factors including social modeling and everyday problems. The cognitive explanation. With this, a fearful response is experienced due to the person's irrational or appraisal of the event. The cognitive explanation believes that phobias form due to 3 main factors. Sensitization, in which the person becomes overly sensitive to an object and begins to associate anxiety with it, which then develops. Avoidance. The next stage is when the person will avoid the stimulus causing anxiety and making it decrease. Irrational or negative thought processes. This is when a person will overestimate negative outcomes and catastrophizes the outcome and underestimates their ability to deal with it. Dinardo, 1988, reported that 56% of dog phobics had a bad experience with a dog, but also 50% of normal control subjects also had a bad experience with the dog, but they didn't develop a phobia. This supports the cognitive approach in comparison to the behaviorist idea of conditioning, because it shows that not everyone who had a bad experience with a dog was conditioned to develop a phobia. However, behavior is not always driven by cognitions. Social phobia is an intense fear of social situations that affect day-to-day functioning. Social phobia is more prevalent in females than males and affects about 8% of people in any year, mostly females in their late teens to late 20s, and who tend to be unmarried and of lower social economic status. 3 to 4% of the population develop a panic disorder with or without agoraphobia, of which 75% are female. When a social phobia is accompanied with agoraphobia, this is the fear of open or public spaces, the situation becomes more serious. Panic attacks in open, public, or social situations can be accompanied by symptoms such as a rapid heartbeat, shortness of breath, chest pains, excessive sweating, feeling dizzy, fear of dying, and fainting. Panic attacks are the result of a heightened automatic nervous system functioning as an intense but seemingly unprovoked fear reaction. According to the DSM-5, in order to be diagnosed with agoraphobia and panic disorder, the criteria include frequent panic attacks, worrying about the episode or concern about the reoccurrence of the episode, anxiety about being in situations that might evoke a panic attack and avoiding such situations. Clark and Wells, 1995, studied social phobias and stated this explanation for panic attacks. Self-focused individuals tend to misinterpret feedback or exaggerate the impact of their actions in social situations. They have negative self-beliefs and interpret how well their social conduct is inadequate. They maintain cognitive bias through safety-seeking strategies, which also maintain the bias. For example, a social phobic may avoid social situations and claim that nobody speaks to them. However, in social situations, they may actively avoid conversation and make little eye contact, and therefore go unnoticed due to fear of rejection. Individuals experience social phobia, acknowledge the irrationality of their fear, and must confront it to overcome their biases and decrease or eliminate their anxiety. The cognitive perspective proposes a more complex explanation compared to the behaviorist perspective, indicating that the brain misinterprets the significance of the feared stimuli and exaggerates the potential outcome of encountering it. Panic attacks can occur without any identifiable trigger, and the physical symptoms can feel very real, including a heightened flight or fight response. This misinterpretation can lead to increased anxiety and bodily responses, creating a vicious cycle that reinforces the panic. Sufferers may use strategies to alleviate symptoms, which can reinforce the disorder. The self-fulfilling cycle of cognitive misinterpretation can explain how panic attacks continue, despite unclear reasons why they start. Thorpe and Skolovskis, 1995, conducted research on spider phobics. 62% believed they would make a fool of themselves, 56% believed they would go mad, and 68% believed they would be hysterical when confronted with a spider. Very few non-spider-phobic individuals reported the mentioned behaviors. Cognitive treatment for phobias helps individuals control their behavior and choose not to be hysterical. The cognitive explanation works to explain social phobias and allows this to be linked with other factors with the influence, the beginning and continuation of a phobia. It also links to the cognitive idea of misinterpretation of information, causing a phobia to be enhanced in a cycle. Sociocultural explanations for social phobias. Parenting styles, life events, and experiences can influence the development of specific and social phobias. Phobic disorders may develop as a result of rejection, emotional neglect, or excessive protectiveness during upbringing. Arundel et al. 1989 studied that agoraphobics reported one or both of their parents lacked emotional warmth or were overprotective, showing how parental styles and events in childhood have a direct effect on the development of phobias. This information, however, should be taken with a bias because it was self-reported by the sufferers, so that there isn't a clear link that this was the link for the development of a phobia. Lieb et al. 2000 had parents assess their own parenting style on a scale and found a link between children with social phobias and the overprotective / lack of warmth parenting style. Phobic patients are also more likely to have had adverse life events in the years leading up to their first panic attack. Kleiner and Marshall, 1988, report that 84% of agoraphobics had an interpersonal disturbance in the month before their first panic attack. The onset of social phobia is linked to stress and uncontrollable events in adulthood or childhood, such as sexual assault, life-threatening accidents, or natural disasters. Phobias may develop as a way to protect oneself from perceived future catastrophes, leading individuals to avoid social situations or stay at home. Agoraphobia has been shown to be passed down genetically through Torsten's 1983 studies, finding that the concordance rate for identical twins was 31% against a 0% rate for non-identical twins. However, this was taken by a small sample and none shared the same phobia. This research is supported by Harris et al. 1983, who found a link between anxiety-prone individuals and family members with agoraphobia. According to Kendler et al. 1992, specific phobias have a minimal genetic influence, whereas agoraphobia is more closely linked to genetic vulnerability. Brain imaging has revealed the brain's regions involved in the fear response, but evolutionary factors must also be considered. Most phobias wrongly activate the limbic system, which is responsible for the fight or flight response. A panic attack is a fast activation of the fight or flight response, and this comes with unpleasant symptoms which teach the body to avoid the stimulus which started it. However, in doing so, the body is taught to repeat the attack in the future. Conclusions of explanations for phobias. Each explanation for specific and social phobias provides insight into a complex subject and is often the most effective to use multiple explanations together to be able to explain phobias. Psychological and social explanations allow psychologists to understand how behavior is learned through life events and upbringing, and how cognition and socialization all play a role in the development of phobias. These explanations, however, are not foolproof and do not explain some specific phobias and social phobias when life events and adverse conditions cause one person to develop a phobia and one person and another to not. Biological explanations give insight into the effectiveness of nature and nurture in terms of how some people can be passed phobias genetically. These explanations help psychologists to understand how phobias developed in hand with genetics and brain structure and processes. To wholly and effectively explain phobias, psychologists should consider all explanations and compare them in terms of each individual's phobia, symptoms, and past. Biological therapies for phobias. Medications are used to help patients with phobias relax and reduce anxiety, but are typically not used alone. They are combined with other treatments like behavioral or cognitive therapy. Anti-anxiety drugs work on neurotransmitters in the brain to decrease the automatic nervous system arousal associated with panic. These drugs enhance the transfer of neurotransmitters associated with improved mood while reducing anxiety symptoms. Benzodiazepines, like Xanax, are sedative drugs used to reduce anxiety levels. They increase GABA levels, an inhibitory neurotransmitter, to alleviate severe anxiety symptoms. However, benzodiazepines are highly addictive and not recommended for long-term use. Once a patient has recovered from the phobia, they need to go through a withdrawal of the drug. Withdrawal from the drug requires careful phasing, as symptoms can be worse than the original ones. Side effects include drowsiness, dizziness, memory and cognitive impairment, upset stomach, blurred vision, and headaches. In some cases, they worsen symptoms and increase anxiety, agitation, hostility, and aggression. This is problematic because it can mean that the patient is left struggling with more problems than before and isn't an effective treatment. However, it can be made more effective by combining it with other treatments. Selective serotonin reuptake inhibitors, or SSRIs, are commonly used to treat anxiety disorders and panic disorders. People with these disorders often have lower serotonin levels, so SSRIs block the reuptake of serotonin in the synapse, allowing for more serotonin in the body, and are effective in reducing panic in people with agoraphobia and social phobia. They have fewer side effects than benzodiazepines, but can cause sexual dysfunction, fatigue, weight loss, apathy, insomnia, and headaches. Due to the side effects, it is hard to assess the effectiveness of biological treatments for phobias because it impacts the acceptability and tolerability of the treatment, and each phobia patient is different, meaning that the side effects and effectiveness are hard to standardize a treatment. There is also minimal long-term data on the use of biological treatments for phobias, so it is hard to assess the effectiveness because scientists do not know what might happen to the patient later on in life. behaviorist therapies, systematic desensitization includes the gradual exposure of the sufferer to the phobic object in a controlled and gradual manner while using relaxation techniques to reduce anxiety. It was developed by Wolpe, 1958, who believed in the idea that two emotions cannot be felt at the same time, so he worked on replacing the anxiety felt from a stimulus with calm feeling through relaxation techniques. The therapy is effective in reducing phobia symptoms and has been shown as to be effective through studies by Lang, 1963, which gives empirical evidence. However, the effectiveness outside of the controlled lab setting does not always work because other factors play into the patient's daily life. It can only be effective for certain cases where it's a specific phobia, not generalized social phobia. Flooding involves a sudden and drastic exposure to the patient's phobia, which overwhelms them and causes panic until they calm down and realize that nothing dangerous will happen to them and there is no merit in their phobia. There is ethical concerns with this treatment, so it's often conducted in vitro, meaning that the doctor tells the patient to imagine themselves in the situation. Flooding can be very traumatic, and therefore there is a risk of it not being effective as it can make symptoms worse. As well as this, there is very little standardization in the use of flooding as a treatment. One therapist may use it very differently and more severely than another, showing how effectiveness cannot be accurately measured. Cognitive behavioral therapy, or CBT, aims to change the negative thoughts and behaviors that contribute to the development and maintenance of phobias. This is developed through trust between the therapist and the patient. It often involves gradual exposure to the fear, also known as desensitization or exposure therapy, and will take numerous sessions to take effect. There is a lot of empirical evidence to support cognitive therapy. Out and Westling, 1995, compared CBT with applied relaxation therapies for panic disorders and found that applied relaxation resulted in 65% panic-free patients after the treatment and 82% after 1 year. Cognitive behavioral therapy resulted in 74% panic-free patients immediately and 89% panic-free after a year. CBT also works effectively because, unlike drugs such as SSRIs, the patient is taught how to cope and recover from their phobia, and therefore is less likely to develop the phobia after treatment. However, it is still uncertain if cognitive or behavioral aspects contribute more to the improvement of patients. Cognitive changes in a patient may result from other factors like medication or lifestyle changes rather than CBT. Conclusions on the treatment of phobias. Each therapy for phobias presents different benefits as well as problems, and like explanations for phobias, they need to be chosen carefully and uniquely for the patient by considering their phobia, symptoms, and what caused the phobia if this is known. In order to make sure treatment is effective, it needs to be tested and used on the right phobia and patient to ensure it can be effective as possible. Effectiveness is hard to measure because every patient and every phobia is complex and not fully understood, as shown by the explanations of phobias. CBT, for example, is very effective in the short term, as shown in studies, but it hasn't been tested enough over time to ensure the longevity of the effectiveness, and this can be a problem in trying to make sure the patients don't relapse into their phobia. This is also the same for systematic desensitization therapy, which is not well researched for a long time. Overall, to fully assess the effectiveness of treatments for phobias, psychologists should consider all developments and use personal judgments to ensure they choose the best treatment for the patient. This is often by using multiple types of treatments. More research and development of treatments is needed to ensure further effectiveness and longevity of the treatment, as well as developing rigid and standardized treatment to ensure a lack of bias. Thank you for listening.